Cornea. We have our chairperson, Dr. Sangwan Virender, Dr. Samar Kumar Basak, co-chairman. We have our convener, Dr. Namrata Sharma, our co-convener, Dr. Umang Mathur, our moderator, Dr. Gokhale Nikhil Sharat. And starting with our first speaker, we have Dr. Srinivas K. Rao.
I don't think he is there. He's not there. He is not there.
Moving on to our next speaker, we'll come back to Dr. Srinivas if he comes and joins us. We have Dr. Gokhale Nikhil Sharat.
Okay. Dr. Himanshu's talk is there.
We can wait for Dr. Himanshu Matalia.
He's there. Himanshu.
Himanshu is there.
I'm right here.
Yeah. So maybe.
Please start sharing his screen.
Is my screen visible?
Yes, sir, it is.
Yes.
Sure. Thank you. And I really appreciate this National Symposium for the Cornea, which is a pleasure to talk in front of such stalwarts. So I'm going to talk about the newer thing in dry eye, and because of the paucity of time, I don't think I can talk about everything, but I would possibly stick myself to post-phase 3 and phase 3 trials which are going on. There are a couple of things which are already there in the market and which is just lurching at the horizon for us and might be available quite soon. One of them is Xiidra, which is levetiracetam from Novartis. This is a small molecule which prevents the T cell activation and prevents the adhesion, migration, and proliferation. And the best part is the onset of action is pretty fast. It's within 2 weeks, the onset of action is. Another thing which is available in US and which might be available pretty soon by Allergan is neurostimulation.
Toward the bridge of your nose. True to your tilt. Hold until tears pool. Remove to clean. Your preferred strength.
So basically, there are a couple of such kind of devices which are available externally. One of the devices available which can be applied externally. The other device, True Tear, has to be put inside, and which helps us increasing reflex steering. Going to the next thing, post-phase 3 trial, there are a couple of molecules which are here. One of them is varenicline nasal spray, which is already there in the post-phase 3, and the data are analyzed. Basically, what's happening here is...
when administered within the nasal cavity, OCO1 activates the parasympathetic nervous system. Through binding to select cholinergic receptors on the trigeminal nerve, causing ion channels to open and a depolarization of the nerve. This further activates neurons within the central nervous system.
So both of them works on similar concept where they stimulate the nerve, whether using a pharmacological compound or using the pain stimulus. The another molecule which is in post phase 3 is called RGN-259. Basically, this is going to be utilized for neurotropic keratitis, which reduces inflammation, increases tissue regeneration, especially conjunctiva and the cornea. And we are waiting for all 3 studies, ARISE 1, 2, 3, and the results, earlier results were pretty encouraging. But as it happens in most of these things, sometime after everything, we may come back to that it doesn't work. Coming to the phase 3 trials, one of them, which is so most of now the molecules of cyclosporin are now trying to go into higher strength of cyclosporin, like 0.1% from 0.05%. One of them from Sun Pharma, it's called Sequa, which is 0.09%, and which is a nanomicellar technology, hence increasing bioavailability. Similarly, Santen has its own Icarus, which is there in Japan and also undergoing phase 2 and 3 trial in European Union, which is a cationic nano-emulsifying carrier, which is increasing the bioavailability of the same drug. Both of them are, mind you, UNIMs. Another one, which is cyclosol by Novalic, which is a multi-dose vial, but that uses very unique technology of isol, which reduces the drop size and it increases the ocular surface retention time as well as the bioavailability. And hence, maybe the effectiveness of this drop may be a little better. Another loteprednol suspension by KPI 121 from Gala Pharmaceutical. Now, this uses a mucus penetration particle technology, which allows the molecule to pass through the mucin chain and hence increasing the bioavailability. Again, the studies, STRIDE 1 and 2 trials are awaited results, and there are more than 900 patients studied there. Another molecule, tivanisiram by Silentis. This is basically, again, a small molecule nucleotide, oligonucleotide RNA, and which reduces the pain and symptoms of the dry eye. And again, the initial trial shows good outcome, but we need to wait for the longer results. Visomitin by Mitotech is another molecule which is available in Russia and which is undergoing trial in US, and which reduces the oxidative stress and can possibly help in improving the dry eye symptoms and sign. Oxervate by Dompe Pharmaceutical, which is a recombinant human nerve factor, which helps us in neurotrophic keratitis and helps in the healing of these things. So with these things, there are the molecules which are there in phase 2 and phase 1 trial, but because of the paucity of the time, I'm not going to touch up. But let me tell you, the future of dry eye is very exciting, and there are a lot of new molecules which are going to come in the market soon. Thank you very much.
Thank you, Himanshu, for a nice futuristic thing and dry eye. So now Dr. Nikhil will be talking on allergic eye diseases.
Thank you, Dr. Basak. I thought I will share with all of you what's new in the management of allergic eye disease, and these are some of the areas where I thought I will share which are the recent developments which are more clinically relevant. So as we all, to begin with, the classification of allergy today is based on the mechanism, which may be IgE or a non-IgE mediated, which is different from just putting 4 entities into a list. And to note is that the severe forms of allergy like VKC and AKC have dual mechanisms. We have a large epidemiology-based study from Hyderabad, where about 26,000 patients of allergic eye disease have been evaluated. And from that, we understand that it's the 3 to 11-year age group which has a maximum prevalence of allergic eye disease, and also that the palpebral form of allergy is probably most common form in our country. The study also shows that about 1 in 10 children and adolescents have allergic eye disease, and it's more common in boys, and it's more common in spring and early summer. There is also a new terminology when we see VKC in adults. It could be either a childhood VKC, which is persisting beyond puberty. That means it continues beyond puberty into adulthood, or it could be a new onset or a late onset adult VKC. So when you see a patient who has a new onset of VKC in an adult, I think it's pertinent that we rule out HIV, because there have been significant association between HIV positivity and new onset of VKC in adults. And in this category, it's probably equal numbers of male and female. IgE may or may not be raised, and there is an association with the CD4 count. So when you feel there is a suspicion of HIV, it's better to get it tested if you have this situation. And unlike conventional allergy, when the allergy is not getting controlled and is fairly refractory, we try to resort to immunosuppressive medications. However, in situation when there is a patient who is HIV positive, especially when their CD4 counts are extremely low, Shankar Netralaya studies have shown us that there is a Th1, Th2 shift, and basically the treatment is to give antiretroviral therapy, which helps to bring the allergy under control rather than immunosuppressing these patients. When we look at antihistamine medications for allergy, Bilastine is a new drug which is available orally in our country, and there have been some studies which have shown that it is probably much more safer. It does not cross the blood-brain barrier. It has less side effects and is more efficacious when you look at patients who have allergy, and is one of the drugs that probably we can use orally as well. There are studies of Bilastine ophthalmic solution under trial, and though we do not have it presently, I'm sure in the time to come, we would have Bilastine in our armamentarium soon. The other drug that is available is olopatadine 0.7%, which is been shown to have a rapid onset and a prolonged duration of action. So once a day dose is good enough. Topical calcineurin inhibitors have a lot of problem with regards to their tolerance and their penetration, and this has been taken care of by using tacrolimus ointment in a merino salves preparation, which can increase the penetration by absolutely around 15 times the ointment, and it might in fact be even effective not only for anterior segment but also posterior segment diseases. As Himanshu just mentioned, the cationic emulsion with a nanodrop technology has been used in the Vectis study for VKC in a 0.1% concentration, and it is well tolerated, and probably it will be something that we also look forward to getting in our country, which may have a good bioavailability on the ocular surface. There are also studies which show us that if you use and treat allergic rhinitis well with intranasal steroids, there is an improvement in the ocular allergy symptoms. And I think this is something that we all need to be aware. And probably the intranasal steroids may, for various reasons, as has been shown in papers, might help the ocular disease. Immunotherapy is the promising option which can change the natural course of disease. And interestingly, in addition to the sublingual and subcutaneous doses that are used traditionally, we also have now newer mechanisms like using intralymphatic and epicutaneous delivery vehicles for immunotherapy. And an oral vaccine is also being tried in Japan. We all need to use a treatment algorithm, and for this, we need to classify allergy based on severity and periodicity of disease. And also, it's essential that we use steroid-sparing therapy with calcineurin inhibitors and try to restrict the usage of steroids and immunosuppressive medication for the most severe grades of VKC. I would thank all of you for your listening, and I think we need to keep working on allergy. There are a lot of unanswered questions, and we still have a lot of patients who suffer either from allergy or from the side effects of the medications that we use. And I look forward to a brighter future with all of us working more on this. Thank you very much.
Yes, thank you, Nikhil.
So much,
nice
Dr.
talk. The next speaker will be, I think, Dr. Namrata Sharma. She is there.
Ma'am, if you could please switch your camera on and start sharing your screen, please.
Namrata is not there.
I'll just check, sir.
No, she is not there.
Not there.
Next speaker is Dr. Prajna.
Dr. Umang Mathur.
Umang Mathur. Prajna was there in the list.
He's not there in the list, sir.
Acha, he has withdrawn. So, Dr. Umang Mathur.
Okay. I'll just get my slides up.
We can see your screen, Dr. Umang.
We are having 1, 2 left. Okay. So we have time. Relax. So 7 minutes, 8 minutes, you can talk.
Okay. So good evening, and thank you for the invitation to this important symposium. I'll be talking on, we've been talking a lot on about viruses. So I'll be talking about the other virus, the Hsv Keratitis. The landmark study HEADS that was reported in the early 90s had very categorically mentioned that topical corticosteroids regime used in HEADS was significantly better than placebo in reducing persistence or progression of stromal inflammation. The other thing it reported was there was no statistical or clinical significant beneficial effect of oral acyclovir in treating HSV stromal keratitis in patients that were already on topical steroids and trifluridine. Now in heads, the kind of patients they call as stromal disease were actually patients like this that had edema and KPs. So this is basically in the newer classification endothelitis and not stromal disease. In fact, their definition of stromal disease was an area of at least 2.5 millimeters square of active corneal inflammation, which was diffuse or disciform, and with hardly any epithelial defect. Now we know the classification now in stromal disease is what we call as necrotizing stromal keratitis or immune stromal keratitis. And what has been described in heads is actually what we call as endothelitis, disciform, linear, and diffuse. Now, if you're talking of stromal necrotizing keratitis, which is often confused with bacterial keratitis and commonly seen in all cornea centers, the study showed that we did that oral acyclovir 5 times a day, along with topical acyclovir, improves the condition, and with addition of topical steroids after 2 weeks, hastens the treatment. This was 70% of the cases were PCR positive, and a conclusion was topical and systemic acyclovir for treatment of necrotizing stromal keratitis facilitates healing of ulceration. Topical steroids after initial antiviral therapy are safe and decreases inflammation and improves visual acuity. Like this case, started off with oral and topical acyclovir, added topical steroids, and the patient eventually heals. So stromal necrotizing keratitis is a distinct entity. In head study, they did not recruit enough patients and it was not reported. But what we call as stromal keratitis in head study is actually what we today call as endothelitis. We also know that there's live virus in epithelial disease, stromal necrotizing keratitis, and uveitis. And today, PCR identification of HSV has become important. It has 100% sensitivity and has become the mainstay in lab confirmation of herpes simplex keratitis. Also, the advantage of PCR is that you can tell about the other pathogens. Of course, the limitation is that it has only 71% specificity. It is more useful in epithelial disease and sometimes does not differentiate between active and latent infection. The real-time RT-PCR commercially available is also pretty sensitive and specific. Now we know HSV has a big problem of recurrences, and the head study showed that by using prophylactic dose of acyclovir reduces 41% of the recurrences. In keratoplasty, we know that the results of keratoplasty in HSV are very dismal, and there are more rejections and reinfections, and only about 30 to 40% of these grafts survive beyond 1 year. Very often we don't choose to do keratoplasty. However, prophylaxis with acyclovir has significantly reduced the recurrences down to 7.4% at 1 year. And so there are fewer episodes of rejection with oral prophylaxis. We know it's a very important disease, causes a lot of morbidity, and vaccine, we wonder now, especially with the talk on vaccines about COVID, why there's no vaccine for HSV. It would be very useful, especially for women, to reduce transmission, general population to reduce recurrences, and to reduce recurrences in family members. Despite many attempts, neither a therapeutic or preventive vaccine exists. Unfortunately, there's very low interest, and I think as ophthalmologists, we need to do some advocacy for this. There are different models, but most of them have been given up. So I think with the new thrust on vaccines, this is the time that we need to work on it. We also see, especially in immunocompromised patients, that acyclovir may develop resistance. There are some alternative therapies, including IV therapy at higher doses, which may have some utility. There are new drugs like foscarnate and cidofovir, which have shown some promise. And these are drugs that are available today for this purpose. However, again, pharmaceutical companies don't seem to be having much interest because there's high safety with acyclovir, valacyclovir, and famciclovir. Thank you so much.
Thank you, Dr.
Thank you very much, Umang. So I think Susan Jacob has joined.
Yes.
She will be our next speaker on newer techniques in keratoconus. Susan, over to you.
Hello.
Yes.
Yeah, can you hear me, sir?
Yes, yes. Please share.
I'm just going to start, so just 1 minute. Just a minute, sir. Please just give me a second.
Yes, yes, we have time.
Somehow I'm unable to see my Zoom screen suddenly.
Mhm.
Oh yeah, where? Where? This one. So maybe you can just go with the next speaker if you would like to. This hasn't happened to me ever before.
I think your Zoom screen is minimized, ma'am.
Pardon? My Zoom is?
Minimized. So you have to maximize it.
Oh, well.
Can you see a small box on your screen? There is a green button over right there.
Just give me a minute. I'll just see if I can. Okay. Yeah, I got it. Thanks.
Okay.
Sorry about that. Very
Okay.
sorry.
Very good.
Okay.
Yes.
Can you see my screen now?
Yes, yes.
Okay, so my talk is on corneal allogenic intrastromal ring segments or CARES, and this is basically something that I started in 2015, and I do have a patent pending for special refines and devices and processes used to create these segments. This is basically a new kind of treatment that was started by me for keratoconus, and the reason I did this or started this or even thought of it was because of the complications that I was frequently seeing using intacts or other artificial rings, and some of these complications I'm sure many of the cornea people would have come across at some point of time or other in their practice. So you can see you can have MELS, necrosis, so on and so forth. This is basically the double-bladed refine that I designed for cutting these allogenic tissue rings, and you can see that this is allogenic tissue ring. Just to come to a video of slightly greater detail about how you do this. You can use any sort of allogenic tissue. Here I'm using donor stroma, donor cornea, and you can see that the first thing I did was to remove the corneal epithelium and endothelium. And once that's done, it's basically more just stroma. You use that punch to cut out the tissue. You get a circular ring of tissue, and then you can go ahead and flatten out the tissue and just go ahead and insert it into femtosecond laser dissected or even manually dissected channels created in the keratoconic patient's eye. And you can see it's really quite easy to put it in. These instruments are just home or theater made instruments just with the routine cataract set. Cut off the excess of the care segment, and then if you're going to do a cross-linking, you can also proceed with the cross-linking at the same setting. So here are some post-operative pictures. As you can see that the cares are seen very quiet, lying very quiet, and you can see different arc lengths. Here you can see the 50% stromal depth that is being used by us, and also you can see here a 330 to 300 almost 40 degree segment here. Anti-segment OCTs and light microscopy of the segment. And we published this in the Journal of Refractive Surgery in 2018. And we found that we had significant improvement in almost all parameters, right from uncorrected to best corrected, visual acuity, spherical equivalent, topographic astigmatism, and so on and so forth. The disadvantages of synthetic implants are a lot of them are done away with cares. So for one, you cannot implant synthetic segments in very thin corneas, especially if they're less than 450 microns, or in very steep corneas, more than 58 diopters. You generally don't implant synthetic segments because of the risk of necrosis and melt, but you don't have that kind of a problem here in CARES. So you can really do it for very advanced cases. And as I'll show you a bit later, you can even do it to avoid DALC in many patients. And also you can also have any kind of arc length or thickness. So it's very customizable right with you in the OR, and you don't have to have a large inventory of synthetic segments that are kept. In addition to that, we already spoke about the complications of the synthetic segments, which are avoidable with this. And also the other thing that you need to remember is that you can also, it's not just for advanced corneas, keratoconus corneas, but also for mild and early cases that you can use this to get a good improvement in the quality of vision. I'm very happy to say that now CARES is being done in a large number of countries. India, of course, we are doing it, USA, multiple centers, Canada, Australia, South Africa, Turkey, Israel, Lebanon, Dominican Republic, Germany, and many, many other countries. So you can do it for a large number of indications, keratoconus, other ectasias. It's been done for post-LASIK ectasia in the US and also for treatment of synthetic segment complications. Here are Scheimpflug images, and you can see that this is pre, the one that's shown in orange, and the post is seen in green. And you can see this synthetic, CARE segment that's placed mid-stromal, and also the decrease in steepening. An image that I've borrowed from Jack Parker, who's also doing a large number of these cases now, and you can see really the amount of flattening, very useful way to explain to the patient about what you're trying to achieve here. And also you can see the difference map in the same patient, giving you almost up to 25 diopters or 30 diopters of flattening also in very advanced cases. It's not just that amount of flattening. If you look at these pictures, you can see here I've put thicker segments, and this other eye of the same patient I've put thinner segments, and you can see the differential effect that you can get by doing this. So here you've got thicker segments, and you've got a much greater decrease, a large area of flattening, steepening in the previously flat axis, both of which add up to a regularization of the topography. And in the other eye, you can see that we wanted to attain a mild effect, and that's what we got. The vision improved from uncorrected 20/40 part to 20/20. A lot of examples I'll just quickly run through. You can see in all of these, you're seeing topographic improvement, different again lengths, arc lengths of CARES, 340 and even 360 all the way through. Asymmetric segments for decentered cones can be used, and that can be used for very, very effectively with very happy patients, because you can get rid of a lot of the coma. Again, asymmetric segment, you can see about 15 diopters of flattening in this patient. And here's again decentered cone, again a lot of flattening, and it's been converted into a regular astigmatism, which of course is much better treated with glasses. And you can see again, as I said, a decrease in coma right from in the 6 millimeter diameter zone, 3.438 to post-op 0.350. That's really significant. Cannot really see my time, so I'm not sure if my time is.
Yeah.
Again, here also you can see the comas decrease from 3.407 to 0.177. So you really get very good effects vision-wise and visual quality-wise. This is a software that's been developed by a good friend, Sherry Awad, and we use this for analyzing our post-ops as well as for the topographic analysis. The segments are implanted at 50%, as I said previously, and the question that I'm always asked is, does it change with time? And people seem to expect it to change with time, but really we have not noticed any substantial change in segment thickness, and this is also been reported similarly by Mario Nobile with his experience in SLAC. And I think this probably is because of the intrastromal location as opposed to the DSEC lenticule, which is not intrastromal. And everywhere else where you use cornea, you put it on not an intrastromal location. So I think once it goes intrastromally, it doesn't change. I'm not sure about the reason, but we've not noticed a great change. Also, cross-linking maybe kind of freezes it in place, but whatever it is, even if it does change, remember that what we're trying to achieve here with surgery is not a mathematical calculation. So it's really not that crucial anyway. Again, lots of other examples. The best thing about CARES is, again, just like Intax, it's reversible, so you can just remove it. And it's unlike DALC, which is irreversible and a done deal for the patient. Once you do it, you cannot, CARES is not like that. It's very reversible, and also it does not prevent a DALC being done at a later date. So we're doing it in a lot of mild cases, moderate cases, advanced cases. You can combine it with cross-linking. You can combine it with bioptics, and as I said, early treatment option. And again, these are cases where I've done it instead of a DALC, avoided DALC with happy patients and avoiding all the post-operative complications that can be associated with DALC. I'm not saying DALC is a bad surgery, it's a beautiful surgery, but really you need to think about the possible complications. So you can give CARES as a way in between and combine it with thin cornea cross-linking techniques. And so you can very often get away with that. So to conclude, we found it to be very effective, stable, simple technique, reversible, adjustable with very low levels of rejection for multiple reasons, which I've mentioned here, but possibly because of lack of time, I will stop here. Thank you so much.
Thank you, Susan. Beautifully. So you continue your innovation on keratoconus. Thank you very much.
Thank you. Our next speaker is none other than Dr. Samar Kumar himself.
Yes.
If you could take over.
Yes. So I'm sharing my,
Screen. Yes, sir.
yes. So is it visible?
Yes, it is.
So my talk is on doubling the corneal utilization during COVID-19 pandemic. I do not have any financial interest. So you see that during this pandemic period, there is a significant shortage of donor cornea worldwide. US by 22%, Europe by 64%, and Brazil more than 70%. But the demand remains almost same. If we see the EBAI data, in the pandemic period, we have minus 80% growth, though the utilization has increased to 21%, but overall transplant decreased by 68%. This is the scenario of our eye bank. You see that sudden there is decrease, maybe 60% level. So the concept of split cornea comes here. The concept is there already. A lot of people has talked about it. One cornea for two recipient or multiple recipient. So this review article shows that if we can use split cornea in easier situation, one ALK and one EK, we can save 1.5 to 3% US and Europe data. And in extreme situation like one ALK and 4/4 DMEC, we can save up to 25% of the donor tissue. During this period, in India, we need a large number of therapeutic or tectonic graft every day as a globe saving procedure. And people are using a lot of techniques, including the glycerol preserved cornea and non-viable gamma irradiated cornea. People are talking about it. There are pros and cons of every method. If you see our data during pandemic, the utilization rate between 97 to 114%. So the concept of this
on the DM side during donor preparation, which is done through a 3 mm stromal window. And naturally, after the window is made, the anterior part of the tissue cannot be used for DALC or other surgeries. In the novel technique using BCL interface, we modify some of these steps. The tissue is first placed on a Teflon block with the endothelial side up, and a 9.5 mm partial trephination is done. It is then stained with trypan blue to identify the cut margins. The peripheral DM beyond the trephination is then stripped off. The DM endothelial edge is carefully identified and loosened all 360 degrees with an elevator instrument. Then, using McPherson forceps, the DM graft is gently peeled from the stroma almost entirely, leaving behind a 1 to 1.5 mm hinge. We then move to a second Teflon block where a BCL is placed and refined to 12 millimeters. Trimming it down to size helps in better air mapping. A 3 millimeter central or slightly eccentric punch of the BCL is done. The trimmed BCL with central window is again stained with trypan blue for easier identification. This is then placed onto the stripped part of the donor corneal stroma. Very carefully, the stripped DM endothelium is floated back on the BCL surface and the water soaked to prevent it from slipping. The hinged part of the donor graft is then separated, and the entire DM endothelium graft is gently centered on the BCL. The interface fluid is soaked so that the graft sticks to the BCL due to surface tension. Now the BCL supported tissue is flipped over and air is trapped so that it doesn't collapse. The exposed descemetes is dried carefully through the 3 millimeter window and the S-stamp is placed as usual. The BCL and DM complex is flipped back. It is then placed on the second Teflon block with the endothelium side up. And now the final 8 millimeter trephination is done. The DMEC graft is carefully transferred to the cup of the donor tissue and stained with trypan blue and subsequently washed with BSS. The stamped graft is now ready. It is then transferred to a Petri dish containing BSS, ready to be loaded into the injector system. The remaining anterior part of the donor tissue is then kept back in the preservative media, which is...
This anterior part can be used for DALK surgery, but we do not have so many DALK patients. So the other use of this anterior part is a tectonic graft, large therapeutic graft. Even I have used this as a Boston K-Pro carrier. So during this pandemic period, we could save 9% of the. So in summary, in India, even before pandemic, there was shortage of donor cornea with increasing demand for corneal transplant. It is likely that we will have to live with COVID-19 for at least next 2 to 3 years. Naturally, the burden will increase in coming years. So the backlog. This is the time to rethink about donor cornea splitting for multiple use for multiple recipient. Thank you very much for your kind attention.
Thank you, Dr. Samar. Do we have Dr. Rajesh?
Yeah.
Rajesh Bagla is there.
Yes, sir. Sir, you're going next. You may start sharing the screen.
You're able to see my slides?
Yes.
Yeah. So I shall be talking about some of my innovations in DMEC surgery. I have no financial interest. Now, currently, DMEC is the preferred technique of endothelial keratoplasty among corneal surgeons worldwide. It results in faster visual recovery with minimal refractive shift and lower risk of endothelial rejection. The common barriers to uptake of DMEC among surgeons transitioning to this technique are the anxiety related to incorrect insertion of the donor tissue and the anxiety related to tissue preparation. In the West, you have the eye banks that pre-strip the donor, or you have the patient-ready DMEC donor. At least in our part of the world, surgeons have to strip their own donor tissue, and there is a learning curve of this process as well. In the learning curve, tissue loss rate may vary between 2 to 20%, and it results in cancellation of surgery, another expense for a second tissue whenever the next surgery is scheduled. This is an illuminated punch block that I designed, available from Coronet, and this was published in IGO. So in this device, it basically provides retroillumination. So when you are preparing your donor tissue, you are able to see the decimus membrane very clearly, and thereby if you have any radial tears or horseshoe tears, you can identify them much earlier and thereby prevent any loss of tissue from unrecoverable damage. You can see the difference in contrast between the conventional and the illuminated trephine. In terms of insertion, there are various inserters made of either plastic or glass. The basic principle is a fluid-based injection. As you inject the BSS into the anterior chamber. Often it results in increase in the anterior chamber depth, and depending on the volume, there is rise in the intraocular pressure. And if the chamber becomes very deep, the donor scroll has larger space to move, so thereby the orientation can shift. And if the wound is not tight, it's leaky, you can have leakage of fluid from the anterior chamber, from the main port or from the side port, and there can be risk of donor expulsion as the donor tissue is inserted. Once inserted, it can go into any of these configurations, and then you have to do various maneuvers to get it into the right configuration and then open it up. The preferred configuration is a double scroll configuration. So we published our technique where we tried to modify some of the technique. One is whether we can achieve a donor scroll configuration in most of the cases. So here, when you load the tissue into the wider portion of the glass injector, you agitate the fluid by a to and fro movement of the fluid. So as you push the fluid, the scroll opens up, and then when it re-scrolls, it can go into a double scroll configuration. So we found that in out of 20 eyes, we could achieve that in almost 85% of the eyes. The other thing is that if you have an inserter with a smaller tip, it results in a faster uncontrolled delivery, and often the donor orientation is lost. And if you have an inserter with a wider inserter tip, you can have a slower controlled delivery with the maintenance of the orientation, but often the AC gets filled with fluid and you have a partial delivery of the donor into the anterior chamber. To overcome this, we propose this concept. You connect the AC maintainer, the flow is on, you insert the tip of the inserter into the anterior chamber, then you rotate the tip so that the DM scroll is facing upwards. Once that is done, you stop the flow in the anterior chamber maintainer and disconnect it from the IV tubing. Now the AC maintainer acts as a conduit for fluid to flow out from the anterior chamber. This is seen in this. You see that we are injecting trypan glue into the anterior chamber, and that trypan glue flows out of the AC maintainer tubing. Now, during surgery, when you do that, as you are inserting the donor, there is no back pressure from the fluid in the anterior chamber. So there is no tendency for the tissue to rush out of the anterior chamber. As the anterior chamber does not become very deep, the orientation of the donor scroll is maintained, which results in easy unfolding as the orientation of the scroll is often in the correct position. So in our series, we were able to unfold the tissue in less than 4 minutes in all eyes, and the donor tissue, the endothelial cell loss was also minimal at 16% at 6 months. If you have the intra-op OCT, this is definitely useful. It can give you in real time the idea about the orientation of the donor tissue. The other thing about the training part is we prepared a donor model which can simulate the human eye when you are practicing the DMEC surgery. So you use a latex diaphragm on the base of the artificial chamber, which behaves like the lens iris diaphragm, so that when you insert the donor tissue into the anterior chamber, by aspirating fluid or injecting fluid within the tubing of the AC maintainer, you can shallow or deepen the anterior chamber. So that gives almost like a real feel to practice the DMEC surgery. This is useful because for the learning surgeon, they can use this to master the technique before they go on to doing surgery for the patients. So this is a short video which shows you once you make that, the donor tissue can be inserted. Finally, in conclusion, all these 4 steps of donor preparation, donor insertion, unfolding, and the practice model for DMEC, these are some of the innovative techniques which can simplify the DMEC surgery. Thank you. Thank you for a patient hearing.
Thank you, Rajesh. So as usual, now next speaker is Dr. Geeta. She will be speaking on innovation in keratoprosthesis.
So, okay. Our next speaker, of course, is Dr. Geeta Iyer.
I hope you can see my slides.
No, not yet.
Can you see it now?
No.
We can, ma'am.
Yes.
Can you see it now?
Yes.
Okay, so good evening, everyone. I'm going to be speaking on cutting edge in artificial corneas, what is new in keratoprosthesis. Under the broad headings of the K-Pro options that we currently have, what were the need for modifications? What is the current updated status with respect to the various K-Pros and the future direction and research prospects? We all know that K-Pros are broadly categorized into the type 1 and the type 2 keratoprosthesis. Indications for each of these are pretty straightforward, with a very small gray zone where sometimes there exists the need for a judicious decision making with respect to choosing a keratoprosthesis. The technique of the various types of K-Pros and the complications associated with them varies significantly.
Ma'am, if you could
Broadly,
make your
yes.
if you could make your slides go full screen. It's okay, go ahead. It's too small. Very possible.
It's on the slideshow, so I'm not sure if you are not able to see it properly.
I can see it, ma'am. You've not clicked on full screen, I think.
No, now it is full screen.
Okay.
Carry on with that.
So, yeah. So broadly speaking, when we talk about a type 1 keratoprosthesis, the indications are a moist eye with no underlying immunological disorders, and the more severe dry eyes which are associated with an underlying immunological condition is reserved for the type 2 keratoprosthesis, and it's addressed by the different types of type 2 K-Pros. And there is a way in which we choose the appropriate type of keratoprosthesis that I shall mention about a little later. So amongst the existing K-Pros that were available, there was a need for modifications in some of them for the following reasons: to basically try and reduce the occurrence of certain complications and to tailor the keratoprosthesis to the patient, as well as to the etiology or the anatomy and the prognosticated functional outcome in each of these eyes. So what were the novel concepts or lessons that we learned as far as the OKP was concerned in the last few years that is currently being implemented in practice? A new method of grading for laminar resorption was introduced. The novel use of bone morphogenic protein in order to regenerate bone in situ was initiated. A process of bone augmentation was initiated to try and reduce the occurrence of laminar resorption, and the technique of keratoprosthesis exchange, whereby one type of keratoprosthesis is totally substituted for by another in case of the occurrence of a complication, was done in cases that required this particular procedure. And all of these that I just listed out were initiated at Shankar Nethralaya, and these are currently being implemented in the K-Pro fraternity. The synthetic OKP, on the other hand, is a research project that is being carried out by the K-Pro surgeons at Singapore and in Brighton. And we look forward to the use of the synthetic hydroxyapatite keratoprosthesis that would largely mimic the OKP and significantly reduce the demand as well as the technique of the procedure. With respect to the Boston type 2 keratoprosthesis, the novel concepts included the use of the BKP2 through the mucosa in select indications, and in collaboration with the Boston K-Pro Foundation at the Mass Eye and Ear, we came up with the use of the Lux Keratoprosthesis, a variation of the Boston type 2 that was designed and made at Boston, a titanium keratoprosthesis that basically protrudes out through the mucosa and by virtue of its material helps in improving the biocompatibility and the biointegration of the prosthesis. This is the algorithmic approach to the type 2 keratoprosthesis that I was referring to earlier, which is a very elegantly elucidated way of deciding which type of type 2 keratoprosthesis to choose. This is an algorithmic approach that's been put together by type 2 K-Pro surgeons among the K-Pro fraternity, and is something that we refer to when we decide the type of surgery that needs to be performed in patients with severe ocular surface disorders. The evolution in type 1 K-pros has by far been the most significant and the maximum in the past couple of decades. There have been refinements in the design and material. A low-cost model in the form of orokeratoprosthesis and Lucia keratoprosthesis are available. There has been an expansion in the indications for keratoprosthesis to include several more in order to increase the number of eyes that could benefit with this procedure. The post-operative regimen has been continuously modified and has recently included the use of post-operative povidone iodine and antifungal prophylaxis, especially in areas which are at high risk, like in countries like ours. Diagnostics has expanded to include ASOCT in order to be able to image the keratoprosthesis and pick up complications at an earlier stage. And preoperative endoscopic fundus evaluation plays a very important role, especially in deciding in whom not to perform the keratoprosthesis based on the posterior segment status. The future direction with respect to type 1 K-pros or any keratoprosthesis is with regarding the research that's currently going on with respect to IOP monitoring, which is probably one of the areas which is severely lacking across all keratoprosthesis. And glaucoma is that one comorbidity which ends up leading to loss of vision in these eyes with K-pros, and we soon look forward to one of these sensors being able to be used clinically by being implanted in the K-pros that we will be putting into the eye. Improving biointegration and surface modification is something that is continuously being researched in order to reduce the risk of melts or laminar resorptions. Slow release of antibiotics from contact lenses probably helps the release of continued release of medications in these eyes. Alternatives to carrier grafts have been attempted either to increase the tectonicity and tensile strength of the graft or as an alternative to the corneal graft in areas where donor corneas are scarce, and attempts are being made to improve the visualization of the fundus intraoperatively by means of wide-angle lenses. So this is just to show a panel that showcases all the various types of keratoprosthesis, and at Shankar Nethralaya we perform all the K-pros that I had listed earlier under one roof, so it's tailor-made for the patients. We have so far done close to 300 K-pros, and our outcomes are comparable to what has been published in literature, both with respect to the anatomic and the functional outcomes in these eyes. And to summarize, we know that K-pros form the last resort for end-stage corneal blindness, and these are meticulous and time-consuming procedures with lifelong follow-ups. As important as it is to choose patient for keratoprosthesis, it is equally important to choose a keratoprosthesis for the patient. And we constantly look forward to refinements and future research in this particular subject and field in order to improve the scope of the use of K-pros as well as reduce the risk of complications in these eyes. And most importantly, timely performance of these procedures and tailoring it specifically to the needs of these eyes can indeed transform lives of these patients who require keratoprosthesis. Would just like to finish by acknowledging the entire team back home at Shankar Nethralaya, our K-pro mentors and our patients. And for those who are interested, we offer a 3-month short-term ocular surface fellowship at Shankar Nethralaya. Thank you for a very patient hearing. Thank you.
Thank you, Geeta. Thank you very much. So next speaker will be Dr. Prabhi. So Namrata has joined us. So,
yes, sir. Yes, sir.
So you will be speaking after that, then because
It
will it
depends.
be all right?
Amrita is the busy
Yes, sir.
one, so we'll
No,
give
I'm
her
okay.
the
I'm okay.
choice
No,
of when.
I'm done with everything. Now I'm here only.
Okay,
Right.
fine. So Prabhi.
Because cornea is my first choice always.
So should I go next?
Yes, please.
All right.
We also have Dr. Vikas Mittal to speak later.
We have time, no issue.
Yeah, one of the rare times when we have time. So, well, my talk is a bit of a departure from what you probably have heard in Cornea so far. And this is more about trying to use different kinds of technologies to be able to stay connected to your patients at all times. And this is something that we realized, obviously, during the COVID pandemic. So the sequence of what I'll speak to you today about is what we used to do typically before the COVID pandemic. I call it BC, what we are doing right now and what we will do after this hopefully goes away. So before, all of us are used to having access to a number of tools for imaging from the point of view of the anterior segment. You image them in all ways, even during surgery. And you do get a lot of data from which you can make judgments about a patient's condition and then make treatment choices. But during the COVID pandemic and even after, all of us have been confronted with lower numbers and also the need to reduce non-essential visits and also to help with remote examinations during this time. So at this time, we already had a system in our hospital where in the vision centers in the villages, the vision technicians used to take photographs using a slit lamp and then share it with the doctor in the tertiary center for diagnosis and for management. This system is working very well. So we wondered if we could actually apply this to the patient as well. So we created a teleophthalmology system where initially it was just making a phone call to a patient. Following this, we actually set up a system where we had a telecounselor calling patients and then interacting with the doctors. And after this, we created a web version of the same system. And the final version that we've been using for over a year right now, actually our anniversary was about last week, we set up a smartphone-based, app-based system. And all through, we've been trying to check if patients have had their issues resolved. And we found that 94% had complete resolution of their issues from the patient's perspective. And this is the app that we use right now. We call it Connect Care. And this is what the doctor has, where they can actually look at their patients' names, their appointments, their waiting list, and what is coming up for them, and has been much appreciated by doctors who use this. So we've seen that the peak of the teleconsultations that we had per month was during the time when COVID was at its peak. And then later when COVID started to abate, then the numbers seemed to come down. But then again, we've seen an upsurge with the second wave of COVID as well. And as of last month, we've completed in the last year, June to May 2021, over 80,000 teleconsults on this system. So how do we do this? We actually use the patient's history to tell us whether the patient has a condition that needs immediate referral, and if his vision is all right, and if he needs to come and see a doctor right away, or if he can be consulted online. We also ask the patient to self-assess from their symptoms, their vision, and also to look at the mirror and describe what they see in the eye. We've also done some research on visual acuity testing, and we evaluated several apps, and in fact published this in IGO a few months ago about the PEAK app that is very similar to your Logma testing in the clinic. Next, we tried to get images from patients, and patients were sharing images on WhatsApp, like you can see here. And typically, these images were not good enough to make a diagnosis in all cases. Some patients started taking images on their phones that were really good, like you see here. And in some cases, the image actually mirrored what you would potentially see on a slit lamp photograph as well. So when we started to see patients who had more serious conditions like infections, graft-versus junction dehiscence, and also rejections, then we started to wonder if we could actually improve our diagnostic capabilities by looking at photographs from all patients. So we asked all patients to send us photographs on WhatsApp, but the problem that we were facing is most of these photographs were either out of focus, they're not in the frame of interest, lighting was not adequate, magnification was not adequate, and only 16% of these images were acceptable to clinicians. So we built a solution, a very simple solution, which is just a holder for a smartphone at a particular distance, depending on the focal length of the smartphone camera, and can be used for any smartphone universally. And this is a system that the patient's attendant can actually take a photograph with. And this comes along with an app on the phone, which helps you to focus and also helps to center the eye And the app also uploads the photograph that is taken to the patient's teleconsultation file. With this, we started to see that pictures started to become a little better. And then we started training the patient's attendants as well, spending 5 minutes with them on how to take pictures and sending them videos. And then we started to get really good pictures on the phone and photographs where we could diagnose corneal graft rejection as well. We also started to be able to see patients and their contact lens fit online. And eventually, when we started grading their pictures, we found that clinicians who are blinded graded more than 80%, 85% of these images as good as a slit lamp photograph. And we found that most of these pictures actually solved all the issues that we were facing with the smartphone. So since during our lockdown period, we found that our patients actually were seeking teleconsultation from across the country. We also thought that we should develop a portal, and we've done that just now, for EMR access to any doctor who would like to refer a patient to the hospital, and also a doctor who would like to book an appointment with LVP, and the doctor who would like to book time to consult a doctor at LVP. We also have set up a home care system where our optometrist travels to the home of the patient, and we've developed several devices like a wearable visual field device, like a wearable pupil measurement device, and also a mobile phone mounted topography device, using all of which the optometrist can capture images and then upload to the portal, and we can do a good teleconsult for the patient. So this is what we have learned and what we've set in practice in the last 1 year or so. Thank you very much.
Thank you, Praveen. Lovely presentation. Now, Dr. Namrata. Namrata.
Yes, sir. I'm just starting.
Okay, fine. Yes.
Go again. Sorry about this. I will be basically talking to you about how does intraoperative OCT help in lamellar keratoplasty, and there are no financial or proprietary interests. It's a challenge to do this in 6 minutes, but so I'll just be showing the videos. So this is a case of big bubble DALC, which is being done here. And I think this was one of my very first cases, and I've not been able to do better than this after that. So bubble is being instilled here at 50 to 60% depth, and nick is given in the overlying stromal layers. And just as a nick is given in the overlying stromal layers, the bubble egresses out, and you can see whole descemet membrane complex which is coming up. Now this can then be reinforced again with the help of the viscoelastic agent which is instilled inside. And subsequently the overlying stromal layers, they are split. And actually the intraop OCT microscope helps you to see the side view, which probably you can appreciate only on the slit lamp. And when it is there, then you know it helps to fine tune your surgery better. So this is a bare descemet membrane over which the graft is now being sutured. And sometimes what happens is it also allows you to pick up or pinpoint the mismatch if there is there between the donor and the host. So if there's some little fluid which is present in between in the interface, even that can be picked up. Now this is a case of macular dystrophy for which the big bubble is being attempted. And notice this is a type 2 bubble because it is coming from the periphery, and it is just stop shot here because you don't want it to go that side. And again AC paracentesis is done here, and it's going to be a very quick egress. The speed of the movie is not changed at all. So it's a very quick egress of the bubble when you give a nick in the overlying stromal layers. And this is basically because probably it is a type 2 big bubble. So very quickly it just egresses out. And even in the previous movie, the speed was not changed at all, where it was such a slow egress. Now this is followed again by reinforcing the supradescemet compartment, and then one can do the surgery as one would do normally. Now, again, if there's a perforation there, of course, you can see that there is a perforation there, but one can monitor the ledge which is going to cover the perforation and leave a little ledge there at the area of the perforation and then do the graft. And this perforation, of course, will be seen as a discontinuity which is there on the Descemet's membrane in the intraop OCT microscope. So this little ledge which acts like a valve is left here, and then a full thickness donor cornea is taken, and this is then sutured with 10-0 monofilament nylon sutures. Now in healed hydrops, it makes a lot of difference because you need to identify the area where the scar of the hydrops is present. And so when one looks at the scar of the hydrops, then you know that when you're doing your dissection at that point in time, you will have to go a little anteriorly. So this is the trephination which is being done here. A nick is given in the level of the stroma, and just as you come at the level of the healed hydrops, you can go a little anteriorly. So that that aid is given by the intraop OCT microscope, and clearly you can just tear off the area of the scar which is present here, which can also be seen here. But because it is paracentrally located, so it doesn't hamper the visual acuity so much. And this is just to show the same, that the paracentral scars do move away from the visual axis. Now, in case of a layer by layer DALC, again, it helps because the adjacent tissue which is present here, you know at what level you are. Of course, now these microscopes have even become smarter because there is a scale which comes on the side. So you actually don't have to compare it, but you actually get a exact measure of where you are. And then layer by layer surgery can be completed. Now in DSEC also it helps because we often do DSEC in very hazy corneas, and sometimes you can't make out where your graft is, but if the intraop OCT microscope is there, here you can't make out, you're very faintly, you have to imagine, but here you know the exact morphology or the topography where the graft is. When you put the air bubble there, even at the submicroscopic level, you know that there is some fluid present, and as you do the hydration of the wound, then this moves. So you know that this is not the end point, but if you didn't have this AIOC2021 microscope, you would probably think that's the end point. So it helps you to fine tune or titrate your step in a much better way. Now, when you do an ultra thin DSEC, such as in this case, the cornea is also hazy, you can't make out which side the graft has flipped. So you look at the curvature of the cornea and you notice that this is upside down, so it has to be like this. And then you can very easily put an air bubble there and get it into the correct orientation. I think about the DMEC, I would just like to show one case, which would be the last case, to show how in hazy corneas it does help. Now, this was a case in which the descemetorexis was done. So these little shreds can be seen here. And S-shaped stamp was also put there, but notice that because the cornea is so hazy, and you have to keep it shallow also, so the S-shaped stamp is not seen. But by the way your configuration is, you can make out in the intraop OCT microscope and unfold the graft with the biceps curl upwards, and then put an air bubble there. And even towards the end, when you put the air bubble, you can see that you still can't make out very hazily. You can make out that there is a S which is in the correct orientation. And this is to show the same. Again, very useful, especially when you have folds which are present, like in this case, air bubble was put, there is a fold there. So by looking at it, you can actually redirect the fluid in such a manner that the fold unfolds and then put an air bubble. So the fold unfolds and then you can put the air bubble. So this fold has now disappeared. So I'm not saying you need it, but then it is a useful tool to fine tune your surgery. It gives you a third dimension. It's like a third eye. It helps you to see the unseen. And of course, I think it will continue to get modified in the near future. And I'm sure it will become cheaper as well as more companies start making it. So thank you very much for your kind attention.
So thank you, Namrata. Our last speaker will be Dr. Bikash. Dr. Bikash Mittal.
Thank you so much, Dr. Basak, and lovely to be here. Thanks so much, All India Ophthalmological Society. So what I am going to do is I am just going to brief what we all cornea surgeons have seen in last 1 or 1.5 years. So when this COVID will be over, I'm sure that this memories, these figures will be there somewhere in our mind. We all will have these memories of, you know, our own cities which have been deserted. The ophthalmologist, as an ophthalmologist, we will also be having this thing in mind, which we have done in all our setups. The thermal screening, the hand sanitization, the PPE, the shields, digital payment, social distancing. We all have done this to ensure that, you know, we as well as our patient stay safe. The different kind of PPEs that we have learned during this time, the mask, the online consultation just now Praveen has mentioned. So this thing will be there in our mind when we will, in this COVID will be over. And this is a sign that, you know, the human race is quite resilient and we tend to come back very fast. When the COVID came, you know, there was blank, and then the eye surgeons around the globe started deliberating, started publishing to help the peers how best we can do. And whatever publications came, cornea was quite highlighted in all, because suddenly there was no cornea tissue at all. You could do a hypermature cataract, but you know, if there's a corneal melt, there's a bad infection, there's no cornea, and that was a really very challenging scenario. The leadership at All India Ophthalmological Society was very aggressive, very proactive in providing all the protocols, first for practice and then for eye banking and how best we can retrieve these tissues. To know what was the actual impact, I called up Ganesh at EBAI yesterday, and look at this. Pre-COVID year, the total number of cornea retrieval in India were 50,000, and in COVID year it was 11,000. The reduction by 77%. And then transplant also from 27,000 went down to 8,000. So this, because there was no retrieval, obviously the cornea surgeon all over globe, all over India have found this challenge. This happened all through. It's not just India, it's happened all over globe. And what we did, how did we come back? We started using the tissues very sparingly, use glycerol preserved tissues also, and whatever tissue are available, that eye bank as well as cornea surgeon ensure that gets utilized well. And look at this map again. Utilization improved in this particular COVID time because we wanted to ensure that all tissue get utilized well. There was lack of transport of medication. I remember one patient who had acanthamoeba and we couldn't somehow get PHMB chlorhexidine, somehow manage with chlorhexidine, mouthwash, and maybe voriconazole. So these were the challenges which we faced. So what we did for, you know, the corneal perforations, we came back to our using our drape or sheet, gluing it with, you know, cyanoacrylate glue, and not only just cyanoacrylate glue, we also used, you know, multi-layered amniotic membrane grafting, and then using fibrin glue. So there thankfully we had some fibrin glue in our stock. That was also a challenge. This tenon patch grafts. So we tried to use whatever things were available, the Gunderson flap, the tenon patch graft, to ensure that, you know, we could somehow save these eyes. So as I said, that to bounce back, we tried our level best to, as a cornea surgeon, whatever best we could do. The teleconsult, Parveen has highlighted so well. This was also an innovation of this time. Even we found that, you know, there were so many corneal transplant patients which can easily be followed on this teleconsult. I will give you a very small example. So this was this 44-year-old pulmonologist. I had done DSEC for her for a failed PK graft 2 years back, and she was doing fine. I remember her graft was very fine, and she had a COVID positive, became a COVID positive, and 3 days after she became COVID positive, she called me and said that, "Doctor, I am having a blurring of vision." So I told her to send me her photographs, and these were the photographs. There was clear-cut rejection. I remember that graft was very clear, and suddenly there was edema. So since she was a pulmonologist, I told her that, you know, we need to give IVMP immediately. She arranged the IVMP, steroids, and then after 2 weeks, she said that I'm feeling far much better, and she sent me another photograph. You can see the cornea graft got clear. So just on teleconsult, also, we know we could manage this well, and she was very happy, and she said that, you know, I have taken these steroids, and now let me know what all to be done. So the basic issue which we found in COVID days was lack of corneal tissue. That was a major challenge. But we, as I said, alternate techniques of saving the globe, and then the teleconsultation, these were the innovation which we found that was very helpful. So as I said in the beginning of my talk, the human race per se is very resilient. No matter what challenge are, we definitely will come back and bounce back with very good colors. Thanks so much.
Thank you very much, Vikas. Thank you very much, Dr. Vikas. So this is the end of our national symposium. So we are little ahead of time of, I think, only
10 minutes.
10 minutes left. So you decide what to do. Namrata?
Yes, sir.
Normally we do not have actually panel discussion in
National Symposium.
national symposium.
We can have
That's
dinner.
all.
So this time we have 13 national symposia. Normally we're supposed to have only 6. I don't know how from 6 they have become 13.
Yes, yes.
I think we, instead of discussion, will take the opportunity to congratulate you, Namrata, and the scientific committee. I think this has been a humongous, I mean, you pulled off something that is quite amazing.
Yes, yes.
Thank you. Thank you, Praveen. But
I just want to convey at this stage that everybody in your committee, every part of your committee, whoever is there, they've been so helpful. Whenever anybody approaches them, every office bearer has gone beyond their scope of duty and just help everybody. Really nice, really amazed to see this teamwork.
see, we had earlier thought we will make it non-paid, but then are we live? I mean, but we
Yes, ma'am, we are live.
We made it. We made registration mandatory, and we have now more than 5,000 registrations, 5,200 paid registrations. I think this is the highest ever.
It's almost same to your physical highest.
But it is a huge challenge. I mean, physical is far easier.
Yeah, and also the support structure that you've built here, all the halls and all your support staff who are doing such a brilliant job. I think amazing. And this young girl, Zubi, I've been seeing in all 2 days.
Who is tireless, absolutely tireless, huh?
People giving her galis for cutting short their presentations, and still she's there till night, which is great. I mean, great support staff you have.
Yeah, so that is what we thought, because some of the senior people, we might hesitate to stop, but she will not hesitate to stop anyway.
All right.
Thank you.
Thank you so much, Dr.
Thank you so
everyone.
much.
Thank you so much.
Tomorrow again, some session somewhere we will meet. Thank you
very much. Have a very good night. I thank all the panelists, chairperson, co-conveners, speakers. Thank you so much for being a part of this session. And it was truly enlightening. Thank you.
Thank you so much. Bye.